My name is Dr. Forrest Cummings, and I'm a board-certified small animal internal medicine specialist. I am here today to talk to you about diabetes mellitus in dogs. Before I get started, I would like to tell you a little bit about myself. Like many of you, I've had an affinity for animals at a very young age. I was always intrigued with biology and how the body worked. My passion for animals carried me to the University of Kentucky to receive a degree in animal science with a minor in biology. I then attended Tuskegee University College of Veterinary Medicine, graduating in 2005 with my doctorate of veterinary medicine. While at Tuskegee, I was introduced to the specialty of internal medicine and immediately fell in love with it. I love the detective work involved in helping to diagnose dogs and cats and ultimately managing their conditions. Following graduation, I completed a rotating internship at the University of Tennessee College of Veterinary Medicine. Rather than applying for an internal medicine residency immediately following my internship, I decided to work as an emergency clinician at a 24-hour specialty hospital while doing relief work as a general practitioner, as I felt this would help me to become a more well-rounded veterinary internist. After 2 years, I started my small animal internal medicine residency, which I completed in 2011, and have been practicing as a veterinary internist ever since. As a veterinary internist, diagnosing and managing challenging endocrine diseases is one of my primary responsibilities. And diabetes mellitus is one of the most common endocrine diseases seen in dogs. Before I get into the details of diabetes mellitus, I would like to provide an overview of today's talk, starting with pancreatic anatomy, pathophysiology, clinical signs, lab work abnormalities, potential comorbid conditions, and management options. Okay, let's get started. The pancreas is divided into two portions. The first portion is the exocrine pancreas, which is involved in digestion of lipids, proteins, and carbohydrates. The other portion is known as the endocrine pancreas and contains a nest of cells called the islets of Langerhans. There are 4 primary hormones that are produced in the islets. All of these hormones work in harmony to maintain a fairly tight range of serum glucose. The alpha cells produce glucagon. Glucagon is secreted when the blood glucose drops below the minimum threshold of approximately 70 milligrams per deciliter. Beta cells secrete insulin, whose primary function is to lower blood glucose levels when it approaches the upper threshold of approximately 130 milligrams per deciliter. Delta cells release somatostatin. This hormone inhibits the release of insulin and glucagon. The fourth cell is known as pancreatic polypeptide, formerly known as F cells. The exact mechanism of action of this hormone is not fully understood. However, it is thought to have a role in satiety, as well as a prokinetic agent within the gastrointestinal tract to help aid in digestion. Diabetes occurs when there is a deficiency of insulin production by the beta cells, or if there is prolonged insulin resistance, ultimately resulting in hyperglycemia. In dogs, they tend to have an insulin-dependent form of diabetes. This is the equivalent to type 1 diabetes seen in humans. With this form of diabetes, there is insufficient insulin production or complete lack of production by the beta cells. The common signalment in dogs include middle-aged females. Any breed can be affected. However, miniature schnauzers, toy poodles, Maltese, beagles, the Bichon, they all tend to be overrepresented. Some risk factors include obesity, hypertriglyceridemia, pancreatitis, genetics, and hyperadrenocorticism, or Cushing's disease. The hallmark clinical signs seen in diabetes include polyuria, polydipsia, polyphagia, and weight loss. Other signs can include cataract formation, distended abdomen, and an unkempt hair coat. Other clinical signs may include lethargy, dehydration, anorexia or hyporexia, vomiting, hematuria, and panting. If any of these other signs are seen, please start to look for concurrent illnesses. After obtaining a thorough history from the owner and performing the physical exam, additional diagnostic tests should include a CBC or a complete blood count, a biochemical profile, urinalysis, and urine culture. Additional testing may also be needed to rule out concurrent pancreatitis, endocrine diseases such as hypothyroidism, as well as hyperadrenocorticism. Potential findings that may be seen on the CBC can include a leukocytosis, which may be the result of a stress leukogram or as the result of an underlying inflammatory or infectious process. Hemoconcentration may be noted secondary to dehydration. Biochemical findings include hyperglycemia, usually greater than 180 milligrams per deciliter, elevated liver enzymes, and hyperlipidemia. Abnormalities seen on the urinalysis can include a normal to decreased urine-specific gravity. The decreased specific gravity is due to a hyperosmotic diuresis secondary to the hyperglycemia. In dogs, a serum glucose of greater than 180 milligrams per deciliter will result in glucosuria. Other findings can include ketonuria and bacteriuria. The glucose that is excreted in the urine serves as a perfect energy source for the bacteria naturally located within the lower urinary system to cause an ascending bacterial cystitis. Please remember to culture every newly diagnosed diabetic as well as any chronic diabetic who is especially difficult to regulate. If your patient has concurrent vomiting and decreased appetite, consider screening for pancreatitis by performing a CPL, a PLI, or a serum PSL. If pancreatitis is noted, additional supportive care may be required, such as antiemetics, pain medication, parenteral fluid support, and transitioning to a low-fat diet. Additionally, abdominal imaging may be required to further evaluate the cause for the vomiting and to look for structural abnormalities within the pancreas. This is accomplished most commonly through abdominal ultrasound. However, if this is unavailable, abdominal radiographs may also be helpful. Lastly, as previously mentioned, screening for concurrent endocrine diseases may be indicated if the diabetes cannot be adequately controlled with insulin therapy alone. This can include screening for Cushing's disease by performing a low-dose dexamethasone suppression test, an ACTH stimulation test, or an adrenal hormone panel. Hypothyroidism should also be ruled out by performing a T4, free T4, and a TSH. Now that we have completed some of the diagnostic testing to help determine a definitive diagnosis or diagnoses, let's talk about management options. As discussed, insulin therapy is key to proper management of diabetes in dogs. Oral hypoglycemic drugs are generally not effective since these drugs work by increasing insulin production by the beta cells. However, remember, in dogs, the beta cells are poorly functioning or not functioning at all. Insulin types include both intermediate and long-acting insulin, For the chronic management, Vetsulin, Novolin N, Prozinc, and Glargine are all approved for use in the management of chronic diabetes in dogs. Please note that both Vetsulin and Prozinc should be administered with a U40 syringe, whereas Glargine and Novolin N should be administered with a U100 syringe. After starting insulin therapy, a glucose curve should be performed 7 to 10 days either in the hospital or by the owner at home with the use of a glucose monitoring kit. Traditionally, a blood glucose curve should be performed for a minimum of 12 hours with the reading taken every 2 hours to fully assess the peak and trough of the blood glucose between insulin administrations. More recently, continuous glucose monitoring has shown an increase in use due to the lack of serial venipunctures, thus decreasing patient stress and discomfort. A Freestyle Libre 2 continuous blood glucose monitoring kit can be obtained from your local pharmacy and placed on the skin between the shoulder blades by a veterinarian or trained veterinary staff member. This comes with a monitor that will allow the glucose to be measured as frequently as every several minutes for up to 14 days, which is the lifespan of the device. The owner can either manually record the numbers and give to the veterinarian to interpret. Alternatively, the data can be accessed electronically through an app. Once an adequate insulin dose has been established to maintain a blood glucose between 100 and 300 milligrams per deciliter, a glucose curve should be performed 1 month later and again every 3 to 4 months. A complete blood count, chemistry panel, urinalysis, and urine culture should be performed every 6 months to assess overall health and screen for occult urinary tract infections. Finding the ideal insulin type and dose is only one piece of the puzzle in successful management of diabetes. Within the past several years, more research has been done to assess the effects of fat in the management of diabetes. Both excessive amounts of adipose tissue and hypertriglyceridemia can cause insulin resistance. It is important to try and increase the metabolic rate to help lower the amount of excessive adipose tissue present within the patient. This can be achieved by something as simple as taking daily walks. Adipose tissue has been shown to have anti-insulin effects, thus predisposing you to diabetes and making management of diabetes much more difficult. Likewise, hyperlipidemia has also been shown to antagonize the effects of insulin. If there is no underlying cause for the hypertriglyceridemia, a combination of prescription low-fat foods and medication would be indicated. This can include such drugs as gemfibrozil and fenofibrate. Both gemfibrozil and fenofibrate increase lipoprotein lipase activity and fatty acid oxidation to reduce the triglyceride levels. Once initiating therapy, measurement of serum triglycerides should be performed approximately 4 weeks later. Ideally, triglyceride levels should be less than 400 milligrams per deciliter after starting therapy. When deciding on the ideal diet, there is no general consensus. A high fiber, low carbohydrate, and moderately low fat diet can be used in cases of an uncomplicated case of diabetes mellitus. However, if there is concurrent pancreatitis that can only be controlled with a prescription ultra low fat diet, the carbohydrate load may cause increased insulin requirements and more difficult management. Furthermore, The same can hold true for patients requiring prescription diets to manage underlying renal failure, food allergy, and liver disease. Remember, in situations like these, consultation with a veterinary nutritionist can provide helpful insight and custom diet options. One major complication of diabetes is the development of ketoacidosis. These patients can present to the hospital extremely ill, secondary to the metabolic acidosis, electrolyte disturbances, and severe dehydration. A characteristic clinical sign is the sweet acetone breath. If the patient is too dehydrated to collect urine to confirm a ketonuria, measurement of serum ketones can be just as effective. The diagnosis of DKA should always be considered a potential life-threatening emergency, and the owner should be advised to transfer to a 24-hour emergency clinic for aggressive supportive care. The prognosis for a patient with diabetic ketoacidosis is extremely guarded and will ultimately depend on how quickly medical management is initiated and the response to therapy. The mortality rate can range from 30 to 50%. Ketone bodies are produced secondary to starvation or prolonged hyperglycemia. As a consequence of the body not being able to utilize its energy source, it begins to break down fats and proteins through a process called gluconeogenesis. This results in an increased amino acid mobilization from the extrahepatic tissues and increased free fatty acid oxidation from adipose tissue, ultimately resulting in an accumulation of ketone bodies, namely beta hydroxybutyrate, acetoacetate, and acetone. At this point, I would like to touch on a common concurrent endocrinopathy seen with diabetes, and that is hyperadrenal corticism. These are the cases that I generally tend to see due to the complexity of the case and the poor regulation of the diabetes. These dogs tend to require higher doses of insulin therapy that may not necessarily decrease with successful management of the Cushing's disease. However, it is important to note that the insulin requirement may decrease once the anti-insulin effects of the cortisol are controlled. The families should be informed to monitor for signs of hypoglycemia after starting veterinary therapy. Some dogs with Cushing's disease can be managed successfully with once-a-day veterinary dosing. However, it is recommended that dogs with both diabetes mellitus and Cushing's disease be treated with twice-daily veterinary or trilostine. Overall, the prognosis of dogs with uncomplicated diabetes mellitus is good, and many can live a normal lifespan as long as complications do not arise and comorbidities do not develop. The prognosis of dogs with complicated diabetes can vary depending on the underlying disease processes and the response to therapy. One last and very important point that I would like to stress is the importance of client education when a diagnosis of diabetes is found. Clients need to be fully aware that treatment is lifelong and will require insulin administration. Asking if they are willing to provide the necessary support is going to be essential in successful management. It is also important to ask whether or not the client has a fear of needles and blood, because insulin injections will need to be given twice daily for the remainder of this dog's life. There is also a financial component that will need to be addressed to pay for medications and necessary diagnostics that will be indicated. If these criteria cannot be met, the conversation should be shifted to discuss either surrendering the dog to someone that can provide the necessary treatment or humane euthanasia. These are not the conversations that any of us enjoy having, but they are important nonetheless and are always aimed at making the best decision for the animal. In summary, we have learned about the pancreatic anatomy, the pathophysiology of diabetes, and potential complications of poorly regulated diabetes, including diabetic ketoacidosis. We also discussed diagnostics to help make a definitive diagnosis of diabetes, as well as comorbid conditions such as pancreatitis, hypothyroidism, and Cushing's disease. Finally, we discussed successful management of diabetes mellitus as well as client education. So I hope you enjoyed this talk on diabetes mellitus and it helps you in your practice. If you have any questions or would like to reach out, you can find me on LinkedIn. Thank you so much for watching.